Now, those that flag positive, those that say, well, geez, yeah, I think they do have a problem, we bring them in for a more detailed evaluation. Some of the tests that we do at this stage of the protocol, we do what's called a pharyngometer and a rhinometer. This is equipment that my company, Sleep Group Solutions, we manufacture down here in Miami. Basically, this is an airway imaging device. It uses acoustics to image the airway, and it shows us where the obstructions are, how severe they are, but most importantly, the most important part of all of this is it shows us how the airway behaves when we change the position of the mandible. So it gives us some objective data that if we reposition the jaw, and yeah, somebody just reminded me too that there's a video showing some of this on Dental XP. So that you guys are all members, you should all be able to see that. Dr. Salama is going through the results, and you'll actually see the pharyngometer test done and the results and all that. So it's a good follow-up to this this little presentation. I don't want to get into incredible details here on the pharyngometer and rhinometer, not to confuse anybody. We look at rhinometry. You know, people ask all the time, well, why do you look at the nose? We look at the nose because I want to make sure there's not a problem up there. I could yank your jaw all over this room, and if there's a problem in your nose, it's not really going to help. So let's rule that out before we proceed with the problem in your throat, the problem that I can dramatically affect, usually with an oral appliance. So the pharyngometer device sends sound waves into the airway. They reflect back out, and it kind of gives us a map of what's going on. It shows us the airway. We can run tests in a baseline position and a neutral position of the jaw. We can use different devices to open and advance the mandible and then retest the airway in multiple positions. It's kind of what the protocol we follow for determining where to take our bite and ultimately make our appliance. Now, consultation here occurs after we take those records, after we see, okay, well, geez, yeah, there really is an airway problem here. At this point, we still haven't diagnosed anything. And by the way, as a dentist, we cannot make a diagnosis. The diagnosis has to come by a board-certified sleep physician. Now, we have people to help you guys with that, and we have a whole network of physicians that are ready and able and willing to work with dentists. So that's not a problem at all. Doesn't matter where you are, I guarantee I could find somebody. I have a new office that came on board in the middle of nowhere up in Alberta, Canada. And believe it or not, we had a sleep doc up there that was happy to work with that dentist. So it doesn't matter where you are. So this consultation occurs after that advanced screening. Basically, you sit down with the patient and say, look, you've got A, B, C, D. You snore, you're tired all the time, you've got high blood pressure and acid reflux. We took a look at your airway. Clearly, there's a problem there. It's really narrow, really collapsible. So now what? Now we need to do a sleep study. That's the only way we can tell for sure if you have a problem. So how do we do that? Well, we can do a home study. You could take the device home from our office here. You wear it in your own bed tonight. You bring it back tomorrow, and we'll see what's going on. Or I can refer you to Dr. Smith down the street, the sleep lab, and you go spend a night there in the lab, and they'll hook you up and monitor you, and we'll find out that way. Either way, we got to know. So either way, we're going to get a study. This device here, it's showing you, it's called the Embleta X100. This is a home sleep study. So this is a device that we set offices up with, we set dental offices up with. And basically, this is a portable monitor. It's very easy to put on. It costs very, very minimal for throwaways. It says $8. It's not true. It's about $5. And it gives us the information we need. We take that information, we send it electronically to one of our physicians in our network. They'll read the study, diagnose it, recommend an oral appliance if indicated, and then send you this diagnosed study back. At that point, you are 100% free and clear, ready to go with an oral appliance. You have a medical recommendation, you have a physician's diagnosis, you're in a position with those things to be able to bill their medical insurance and get reimbursed for the appliance. It's really quite a very clean, clear-cut system. So the mBlood is great, and we're seeing a huge amount of home testing happening now, and more and more than ever before. So this is becoming more mainstream. I can say with some confidence that in the coming years, this will become the gold standard, and in-lab studies might only exist on severe or complicated cases. Here's an in-lab study. The big difference is the cost. You're talking about a study that you might bill $200 or $300 to the insurance for from at home, where you could be $2,000 or more in a lab. So, the insurances are actually what's driving the home sleep testing business because it costs so much less. Once we have a sleep study, whatever the means, it's going to be diagnosed by a physician. And again, if indicated, if they fit the criteria, there'll be a recommendation written right on the study saying we recommend treatment with an oral appliance. Perfect. So that's your golden ticket to move ahead. And at that point, you just sit down with the patient. You can confirm what they have now. You can explain sleep apnea to them. And I'll tell you what, physicians do a pretty poor job of this, been my experience anyway. I've talked to hundreds of people that have had sleep studies. And one of the most common reports I get back is, well, geez, they didn't tell me any of this. They're telling me I'm going to have a heart attack and this, and I stopped breathing 400 times and for a minute and a half once, and they didn't tell me any of that. They just told me I need to wear this crazy mask. Well, that's the difference. So a little 10-minute consultation here will just blow them away when you really explain what occurred and how sick they are. Then you say, look, the physician's recommending we try an oral appliance. That's it. They're sold, and you don't have to do anything. I told you I'd explain CPAP. CPAP, C-P-A-P, stands for continuous positive air pressure. This is the gold standard treatment for obstructive sleep apnea. It works 100% of the time. Everybody who wears their CPAP has no apnea. Wears their CPAP is the key word there, and so many people are put on this, and they're just intolerant to it, or they refuse it outright, or they even hear that they're going to be put on it, and they say, forget that, I'm not going to do it. So compliance is a big problem with CPAP, but this works quite well. Some of your patients are going to be so severe that they have no choice. This is their one and only choice. So, it's not our competition. My goal is to never, ever take anybody off of CPAP. If you're wearing it, that's fantastic. I want you to keep wearing it. If you took it and put it in your closet and never touched it in 2 years, well, now let's talk about appliance. Here's some of the different masks and devices out there. One of the things that's changed over the years, that's made, again, one of the big changes that occurred. One was the Academy of Sleep Medicine recommending oral appliances as a first-line treatment. The second thing was the Academy came out, and Medicare actually came out and said, look, we're not paying for CPAPs anymore just out of pocket. That's not happening because we know everyone who's told to wear one, a lot of them are not. So they started monitoring. This little memory card on the side of this device up here on the side there, you see, that little memory card tracks hourly usage. If the patient doesn't wear it enough hours, they don't pay for it. The insurance company pays only based on compliance. So that's a big change that occurred, and what it's done is it's forced follow-up. And now, for the first time, the physicians in the medical side are aware of who's wearing their CPAP and who's not. Now, oral appliances. Probably the most common question I hear, and I get a lot of crazy questions. The most common one, which appliance should I use? I don't know. Use whichever one you think is prettiest. Now, I don't want to belittle that question because it's an important question. It doesn't matter is the proper answer. And anybody who tells you different is straight up lying. Now, what does that mean? Well, the appliance itself, what is it? It's a piece of acrylic that repositions the mandible. Okay? What fixes the apnea? Is it the appliance? Is it the pretty little purple, yellow, blue, green acrylic, whatever it is? Or is it the position that it puts the mandible in? The position. So all other things being equal, if all the appliances can put you in the same position, then it doesn't matter really which one you're using. What matters is finding that darn position. Because if they're all in the wrong spot, none of them work. And that's the truth. That's the bottom line. So our protocol focuses on not picking one of the dozen or two decent appliances out there. It focuses on finding what position their mandible needs to be in, and then simply taking records and building an appliance that puts them there and does it comfortably and does it in a way that they'll continue wearing it. That's what makes our guys and our dentists so much more successful than the average person doing this, because they're not guessing on position. They're not saying, let's just crank you forward, lock you down, and give it a try. What the heck is that? That's just so random, it's scary. And a lot of people don't get involved in sleep because they see that and they're like, well, geez, that's just so arbitrary. Oh, there's better. There's ways to get around that. Like I said, we'll talk about that. So here's the pharyngometer done again. Oh, it's weird. I'm missing a couple pictures here. I'm sorry. But basically, what we would do at this stage is we would run a pharyngometer test on someone, just like you see in the picture, except this time we're going to open the mandible and advance it. And we have a little kit. It's called Airway Metrics. And there's those little bite jigs, little plastic bite jigs that reposition the jaw and hold it there in a measurable spot, so long enough that we can run a test and see how the airway responds. If we don't get a good response, then we might open them up another millimeter. We might advance them another millimeter. Micro changes have huge impacts on the airway. And before you know it, we've found the vertical and protrusive position that really cranks that airway open. And it's not always maximum. Coming forward as far as you can does not always work. Opening as far as you can does not always work. There's a happy middle in both directions. We got to find it. Once we find that position, we take our records, and now it's just, now we send them to the lab. Now we get an appliance made, and there's plenty of good ones. I'm showing you here the TAP appliance. It's probably one of the most popular lab-fabricated appliances to treat sleep apnea. Been around a long time. There's pros and cons to each one, and this is something that we can cover in much more detail when we are doing the live courses. We hand out the appliances and you see them. And I don't want to get into crazy detail on these now, but the bottom line is there's pros and cons to each. This is the Respire. This is a real new appliance, Respire Medical up in New York. Very popular design. This is called a dorsal design, meaning that the upper and lower appliance are completely detached. So you see here with the pointer. The upper and lower are detached. The lower has this little vertical fin here, and that engages this little block on the upper, preventing the mandibular piece from falling back behind it. We can adjust it just by cranking the screw and doing micro 1/10 of a millimeter per turn, so we can really advance them out slowly if need be. Patients really like this style because it's comfortable. They can open, they can yawn, they can chew, swallow, whatever. So that becomes, I guess chew is out of it, but you can swallow, you can take a drink of water, you can talk, sort of. So it's quite comfortable. I'm wearing one of these now personally. I've worn it for probably 6 months or so. It's been quite good. I like it. Cost-wise, one of the lower cost ones out there too from the labs. EMA, again, fantastic appliance. Been around a long time. Dr. France is one of the nicest guys you'll ever meet in this field. You'll find nobody say a bad word about him. He's a super nice guy. Very comfortable appliance, real low profile. Achieves advancement by these little elastic, these are called durometers. They're a little rubber strap, basically. And you could take that rubber strap, and by putting a shorter one on, you advance the mandible. Downfall to that is that strap needs to be replaced over time because patients will pull against it and stretch it out. Now, bottom line here, again, I can make no attempt to cover all the appliances. There's dozens. We do go over more in our regular live courses. But the bottom line I want you to get is it's not about which one. And you can't just leave and say, okay, I'm only going to make TAPs or I'm only going to make Respires. That doesn't work. Just say, I'm going to make which one seems appropriate for the patient, which one they choose, which one is most comfortable, after you've tried them yourselves. But I'm going to put it in position that's effective. I'm going to take a bite in a position that I know improves their airway. And patients that I see no improvement on, I'm not even going to proceed with. And by doing that, your success rates are going to be incredibly high. Follow-up study, I always tell people don't rush this. And the follow-up study is really the absolute necessity for home sleep testing in a dental office. You can diagnose everybody with a sleep lab. You can refer every patient out for diagnosis, and they can go through that sleep study, and it's fine. It'll work quite well. But everybody who has an appliance also needs a follow-up study to verify efficacy. This is a must. You must know what that appliance did. You can't just rely on the patient saying, well, geez, I stopped snoring and I feel great. That's fine. That's a good subjective improvement, and if they tell me that, I'll probably do the follow-up study right away. But that still doesn't mean you can go without it. So everybody that gets an appliance gets a follow-up home study to verify that what you did works. That's it's a kind of cover your butt step too. You need to have documentation showing that you have effectively managed or you've achieved maximum medical improvement with this life-threatening condition they have. So everybody gets follow-ups. Some offices will do it yearly too. Send a quick study home. Doesn't cost you much, just as part of the treatment. And that's not a terrible idea either. Again, I make no attempt to ever get into a position where we're going to get into crazy detail about insurance billing. I just wanted to throw this out there and say these are covered procedures by medical insurance. And this is a typical case. This is a huge range. But I would tell you that a typical case should be in the $3,000, $3,200 range, typically. And you can charge whatever you want, but I would say throughout our several hundred offices, that's about what we're seeing charged. There's not a crazy amount of codes or procedures, but it's real cut and dry. There's coverage for it. People get reimbursed. You can get reimbursed if you want to accept benefits. Again, there's always tons of questions on insurance. I'm happy to answer those privately. There's obviously no time to get into it now. There is coverage. It's gotten incredibly better. And the only thing I'll also say about this is Medicare has come out now with LCD determinations, basically saying they're going to start paying for oral appliance therapy to treat sleep apnea also. And that's effective January 2011. So latest and greatest news right here. What do we need to submit to medical insurance? We need a diagnosis. We need a prescription, a recommendation from a physician saying you need an oral appliance. It's nice to have the patient say, I don't want to wear CPAP, if that was an option. And we documentation showing appliance efficacy. It's always good to be able to submit and say, look, what we did worked. This treatment that we're billing you for wasn't just unsuccessful. It actually managed their apnea. So those are not difficult things, and obviously we'll touch more on those if needed.